Hi, my name is Dr. Fatima Cody Stanford. I am an obesity medicine physician scientist at Massachusetts General Hospital and associate professor of medicine and pediatrics at Harvard Medical School here in Boston, Massachusetts. It is a delight to be here with you today as we talk about obesity in adolescents and children. And we're going to start with looking at how obesity is measured and defined for adolescents. Let's talk about that. Now, usually it's classified by a body mass index of greater than or equal to 30. Now, this is really important as we talk about this, particularly as body mass index has been somewhat controversial, and it's a topic that I really talk about quite a bit in a lot of my deliberations. Now, when we're looking at this for children specifically, we're looking at this and thinking about growth charts. This is usually looking at the growth charts and looking at between the 85th and the 95th percentile on the growth charts, particularly at looking at overweight and obesity respectively. What do I mean by that? So between the 85th percentile is when we're looking at those that have overweight, and when we get over the 95th percentile is when we're looking at specifically those that have obesity. So between the 95th and higher is when we're looking at obesity. Now, when we're looking at waist circumference and waist to hip ratio, these are better predictors of both all-cause and all-cause mortality than BMI. That's really important for us to think about in terms of really giving us a sense of the risk of someone in terms of, something like dying. And we don't really like to think about that, but it's important for us to think about that because underestimates of obesity prevalence in adolescents are really important, particularly when we're looking at things like body fat. And body composition is used more frequently in adults than children, but adolescents are closer to adults than children, and we have to be really aware of this. Now, when we're looking at central adiposity, what do we mean by central? That means weight we carry in our midsection. This is linked to metabolic syndrome. Metabolic syndrome increases our risk of things like type 2 diabetes and metabolic associated steatotic liver disease. Oh, that's fancy. This is a new word that we use for fatty liver disease. So this increases our things for liver disease, and liver disease is more likely to be associated with metabolic conditions. So we really need to pay attention to that liver fat or that fat that we carry around our central region because that really increases our risk for conditions that we are unaware of if we are carrying it in our central region. We'd rather carry that fat, that central adiposity, around our hip, buttock, and thigh region. Now, what does the American Academy of Pediatric Guidelines recommend for starting pharmacotherapy in adolescent patients, and what treatments are available for individuals? They recommend combining lifestyle modifications for age that are 12 and above. And just as we just mentioned, they say start treatment as early as possible, particularly those with comorbid conditions and those with severe disease. Now, what is approved for use? The Orlistat, which has been around for quite some time for age 12 and above. This is a medication that can be used, obtained either over the counter at your local drugstore or with prescription with your physician. It's used in adolescents. There are some adverse effects associated with it. Now, prescription only, phentermine and topiramate oral, 12 plus, or liraglutide and semaglutide. This is when we're getting to those GLP-1 agonists, our glucagon-like peptide 1 receptor agonist, approved for age 12 and above. This is a sub-Q injection. So these are things that can be utilized in the pharmacotherapy realm for our adolescent patients. Now, over the short course, we can use other agents. A drug like phentermine, which has been around since 1959, approved for 3 months duration for age 16 plus. This is dose dependent. Some adverse effects that can be associated with this, but we need to be working with clinicians that know how to use this, that have been using it for many years, like myself. Or we can use off-label lisdexamfetamine, approved for binge eating disorder. This has to be prescribed by those that also know how to use this. This is used in adults, but used off-label for children. I can tell you that I've used this for quite some time, seeing really great effects for those that have binge eating disorder. Please note, binge eating disorder is the most common eating disorder in the American population, both in pediatric and adult populations. Now, semaglutide, which is that long-acting GLP-1 receptor agonist, and phentermine plus topiramate are often used in adolescent patients. Now, what do the data show about GLP-1 receptor agonist efficacy and safety for patients with obesity? I can tell you that I've used this for quite some time in patients with obesity. I have a lot of experience with using this. And what we can see in adults is semaglutide has reduced weight by about 15% of total body weight versus 2.4% in placebo. And when we're looking at tirzepatide, which is that combined GLP-1 GIP, GIP is a glucose insulinotropic polypeptide, so it's a dual agonist, 15% versus 21% efficacy in terms of total body weight loss versus placebo. Now, liraglutide, which was that first generation once daily dosing, showed about 8 kilograms reduction of body weight versus 2.6 kilograms. So a lower efficacy than those kind of more potent GLP-1s that we just talked about. Semaglutide and tirzepatide reduce 10-year risk of type 2 diabetes. So these are very efficacious in the type 2 diabetes realm. Of course, GLP-1 receptor agonists were first approved for the use in patients with type 2 diabetes. And we know that semaglutide did reduce death from cardiovascular causes, non-fatal myocardial infarctions, non-fatal stroke in patients with existing cardiovascular disease without type 2 diabetes. So that is really major for us to look at. Now, semaglutide reduction in symptoms and physical limitations are greater improvements in exercise functions, greater weight loss for patients with type 2 HFpEF, which is heart failure with preserved ejection fraction, and obesity. That's major. So major issues that we're seeing in resolution with these high potency GLP-1 receptor agonists. And we know that semaglutide definitely improved major issues in patients with adults with overweight and obesity in terms of kidney function with preserved ejection fraction. So we have seen major issues improved across the board in major organ systems when we're looking at these patients. Now, let's focus on adolescents because that's what we're here to really talk about. Let's look at liraglutide. Remember, liraglutide is that once daily injection that we have initially used, and that was the first medication approved for use both in adults and in pediatric patients. So this showed a BMI difference of 4.6 percentage points relative change in BMI. And this was really important for us. It showed no noted differences in glycemic, cardiometabolic, and weight-related quality of life, however, with this particular medication. However, when we moved over to semaglutide, that higher potency, we showed a 16% difference in body weight loss. So we found with adolescents that they actually lost a little bit more weight compared to the adults with semaglutide. Significantly more people achieved BMI reduction compared to greater than 5% with semaglutide. And there was a significant reduction in waist circumference, hemoglobin A1C, total cholesterol, low-density lipoprotein, VLDL, triglycerides, and liver function tests. No significant difference in blood pressure or HDL cholesterol, and there was improved weight-related quality of life. So you can see the differences in that low-potency liraglutide versus that high-potency semaglutide. What should patients and parents know about the risk and benefits of the administrations of GLP-1 receptor agonists? They're effective at weight reduction. There's the potential for beneficial effects on cardiometabolic and renal measures as well, like we talked about. There is weight rebound if we discontinue these. We didn't talk about how these work. These work on how the brain and gut sees weight. They stimulate the brain to want to eat less and want to store less adipose or fat. When we stop these medications, you can imagine that these things that were being fixed are no longer being fixed, okay? These adverse effects that are most common are mostly mild and moderate. The most common things that we actually see are nausea. Nausea is the most common side effect associated with the administration of GLP-1 receptor agonists. Other things you might see, headache and dizziness, associated with decreased intake of food and nutrients. We can mitigate by encouraging intake of food and nutrients, particularly high protein, high protein and vegetables and things of that sort. Risk of really significant side effects are rare. They can include pancreatitis or gallbladder disease, acute kidney injury, and heart rate increase. Very, very rare, very uncommonly seen, but these are the things that we want to pay attention to. Now, where are these medications contraindicated? We will absolutely not use these medications in patients with a personal family history of medullary thyroid cancer, persons with multiple endocrine neoplasia type 2, and those who are pregnant. Absolute contraindication to use. We do want to titrate these medications accordingly. For example, semaglutide has 5 doses, 0.25, 0.5, 1, 1.7, and 2.4 milligrams. You cannot advance these greater than 1 month, okay? You need to stay on that dose for at least 1 month. For example, do not go faster than that. Liraglutide is a once weekly dose titration schedule, but sometimes when we're in actual practice, we may need to slow the titration schedule to mitigate the side effects, okay? And that's what we need to really pay attention to. Pay attention to the patient in front of you and make sure you slow the titration to mitigate side effects. Now, how do you discuss the GLP-1 injection technique with adolescents? One of the key things I always like to do is I like to use the abdomen. The abdomen is a nice area for injection of the sites, or injection of these medications. And so the abdomen is a nice bed for injection. And I find that my adolescent patients do really well. Actually, they do much better than a lot of my adult patients with the injections. And so that's really, really, really important.